So moving on to the next topic, would like to invite upon Dr. Suman Ramchandra, who's the consultant physician and diabetologist at Madhumeha Healthcare, Bengaluru. Welcome you on stage, doctor.
At the outset, I would just like to thank Dr. Srinivas Murthy and IELTS Academy for giving me this wonderful opportunity to chair a very important session by Dr. A.K. Das. Most of us know Dr. A.K. Das. A.K. Das is the professor and dean of the head of endocrinology at JIPMER and MGM University at Pondicherry. Just to give you a few highlights about Dr. A.K. Das, that A.K. Das was he's a dean in academics of Balaji Vidyapita, and also he's an eminent professor at Mahatma Gandhi Medical College and Research Center. He's also been in a lot of, as a president for national chapters of API and ASP, and also he's also possessed a rich, vast experience having expanded credentials in the global recognition, including the King's College of London, and he has worked in various institutions. And I just really welcome Dr. A.K. Das to talk about the public strategies what we commonly use for the obesity adult management. Over to you.
Thank you, Chairperson sir, for a very generous introduction. Dear friends, this is a talk which will be published under the title, The Imperative Choice. We have called it Men, Countries, Countrymen's, Parents. The choice is imperative. The imperative choice is to control, to contain the adolescent obesity, and I'm discussing that only from the point of view of public health strategy, how to prevent, how to manage. I work for the Government of India. I'm the member of the NCD Conclave. So I'm bringing this presentation from the Government of India, NCD Conclave. And what I'm presenting today are all from the various types of work, activity we have done all over the country. Now, this is a very big agenda, but I'll take not more than 20 minutes. Why this topic matters? What are the important insights and the global magnitude problem? What is geographical variation and current India, what is the situation of adolescent obesity? You will be astonished to know the numbers, and I have brought the World Obesity Atlas of 2026, released 7 days back. Now the coexistence of undernutrition, overnutrition, obesity, we call it double burden. We have something called obesogenic environment. If public health can abolish that, we are all out of it. Number 2, the biological factors, the behavioral factors, very important, which we have to modify. And we talk about the life course perspective, because it's very important to approach it from the life course, not at when the person is already obese and adolescent. Now, and we also talk about the downstream effect and the upstream effect. The cardiovascular vulnerability, very important. We lose students, type 2 obese diabetic adolescents, because of heart attacks. Therefore, the cardiovascular vulnerability, psychosocial vulnerability, and the economic impact, the spectrum of prevention, from early life prevention to the policy that we must enact. Assessment, how do we assess? What therapy is available? I will not go into details of that. AI, digital health, and how we have applied in a public health approach that for the obese adolescents, and some innovative public health approach, and some, I call it 3 things we talk in Government of India: impact, we call it core tips, and we say summary. So the last 3 slides will be on that. Suffices to mention that adolescent obesity has become the most important contemporary challenge from the public health point of view. It is not only a cosmetic or lifestyle issue. We call it a serious medical condition. If you do not consider obesity in adolescent children as a medical condition, we are doomed. We are doomed. Now, therefore, and it has effect on the physical, psychological, and the social well-being. Now, adolescent period is important because it is a time of rapid growth, rapid hormonal change, and rapid behavior formation. I'll show you by example how it affects. Now, unhealthy habits that develop during adolescence continues into adulthood, making early obesity a strong predictor of early adult obesity and related all NCD. Obesity in adolescence is associated with 2 things: many immediate problems and many long-term problems. What is the immediate problem? I have put it together to cut down time. Number 1, immediate problem is IR, insulin resistance, pre-diabetes, type 2 diabetes in the adolescent. I'll show some slides. Hypertension, dyslipidemia, fatty liver disease or MASLD, sleep disturbance, orthopedic problems, and menstrual irregularities. This is called 8. It is called dirty 8 that can occur in the immediately in adolescent. Long term, it can produce 4 things, which Malaya said: CVD, cardiovascular disease, it can produce kidney disease, it can produce metabolic disease, and ASLD, MSLD, and premature mortality. Can any one of us ever witness the mortality of our child? That's what is happening. These adolescent obese who are becoming very severely obese and developing type 2 diabetes, developing hypertension, the life is cut short. That is the theme of my talk, that we can reverse it, we can control it, we'll see how. Now, beyond physical health, adolescents today have psychological problem, they have low self-esteem, they have body shame ideas, body image esteem comes down, anxiety, depression, bullying, and social isolation. Many of the obese children, we did study, have been socially isolated. And these problems may negatively impact the academic performance and overall quality of life. Now, you see why it is increasing and why we cannot stop it by stopping that. Is rapid urbanization. Can we stop it? Sedentary lifestyle, we can change it. Unhealthy dietary pattern, we can change it. Increased intake of ultra-processed food, excessive screen time, reduced physical activity, poor sleep, and environmental influences. Dear friends, there is a dose of genetic, but none of the children can choose their parents. They're already born. So genetic only loads the gun. The environment which pulls the trigger, we can change it. Now, these factors do not occur only in personal area. It occurs in the family, school, community, workplace. Therefore, the policy level, we from Government of India target obesity, especially adult obesity, from the point of view of multi-level addressing. It requires public health approach which combines prevention, early detection, lifestyle modification, community awareness, school-based intervention, and supportive policies. What is obesity? I know details of it. I'll just cut down the time. Now, dear friends, this is very important to tell you. This is a diabetes conference. ILET is the diabetes conference. So I'll do talk on adolescent obesity. I'll spend 2-3 minutes extra on this adolescent obese diabetic. Now, there's an increase in the diabetes prevalence preceded by increase in weight and obesity. Obesity driver and the differential impact on the population, like East Asia, India. You know, I chair 2 things, Chairman Sir. I chair the Young Diabetes Registry for the Government of India. I also chair the famous ICMR INDAB study, which is from Government of India. This is because of my standing as a Director General Health Services. So therefore, I must tell you that both the studies, both Young Diabetes Registry and the ICMR INDAB study has clearly shown that early, that is adolescent diabetes and young diabetes, I'm talking type 2 only, are a great problem for India. Great problem. I'll show the numbers in a minute. There's a female preponderance, 2.3:1 in indigenous population. There is exposure to overnutrition. And you know what is important? That we have differentiate the adult type 2 diabetes mellitus from the T1 diabetes mellitus, because this adult, the young type diabetes occurs also between 12 to 19 years of age, and adults onset type 2 diabetes mellitus is a different kettle of fish. Now look at, it is no longer a problem of few high-income countries like USA. It has become a global problem. That's what the new atlas says. Now, I'll show the new atlas values. The old WHO values given 2 years back. It is the obesity in the adolescent between 5 and 19. This is their classification. From 1.9 in 1990 to 8.2 in 2022, and 6% girls and 8% boys, but you'll see number is very high. The burden is not evenly distributed. In many high-income countries, prevalence runs high, where the low and middle-income countries like ours, the number is still rising because of, I told you, I'll repeat again and again, the nutrition transition, urban living, total nil. In ICMR India, we found there is nil physical activity. About 80% do not do any activity, and increased intake of ultra-processed food. And you know, therefore, it's very important. This slide is one of the key slides. I like to have your attention. These have taken from a new paper just now published in the Diabetes Care 2-3 years back, but now it is getting importance. It was written by Nikhil Tandon, by V. Mohan, and all the foreign authors you see here. Now, previously, we knew that the juvenile diabetes is type 1 diabetes. And adult onset diabetes is type 2 diabetes. We studied that 40, 40, 40, above 40 in fatty people. 3 decades ago, the pediatrician for the first time described that the clinic-based investigation, they described that there is a type 2 diabetes in children. And studies monitoring the youth onset type 2 diabetes in Americans first and in YDR next decided and showed that the type 2 diabetes in children is double the number of type 1 diabetes. I'll repeat again. Please remember, type 2 diabetes in children today is double the number. You may not be seeing it if you're working in the government civil hospitals. Bitul is here. But if you're working in a private hospital, or working in a private medical college, if you're taking the country as a whole, the number of type 2 diabetes in the young people between say about 10 to 20, obese girl, obese boys developing type 2 diabetes has become double the number of type 1 diabetes. That's very important. So it is said that the youth onset type 2 diabetes may be rare. That is the onset beyond 20 and 29. But very important in children and adolescents, this is very important. Why is it important? 3 points. Number one, it has an aggressive clinical course. This has been shown by all of us together that type 2 diabetes in the adolescents has a rapid, very aggressive course associated with debilitating complications and high all-cause mortality. This is the very important message that I like to give, that adolescent obese people, obese adolescents becoming diabetic, we have to take care of it. Dear friends, I will give variation to save the time. This is published, so I'll give you the paper. There's a state-to-state variation, more urbanized states. I will know details of it, all same thing. Now, in the current Indian trends, now in the adolescent obesity rising, if you pulled obesity data 12.4 and 8.4, I will say that highest burden of the countries which have the obesity from the eyes of an in-depth study are Pondicherry, Chandigarh, Delhi, Punjab and Tamil Nadu. In Punjab, 1 in 3, Bitul sir, 1 in 3 adolescents are obese. 1 in 3, 33% are obese. And you know, this is the one I'm referring to. This atlas was released very recently by Prime Minister was there, Health Minister was there, we're all invited. Now, what is the message it gave? Children between 5 and 9 years with overweight or obesity in 2025 was 15 million. 14.91, make it 15 million. And the children between 10 to 19 years, which I am talking today, one portion of that, 10 to 19 years, overweight or obese in 2025 were 26.5 million. See this staggering number, And you know, the number of children between 5 to 19 years with disease indicators attributed to high BMI. High BMI, what disease produced? You just see in 2025, the number of children with BMI as attributed hypertension, 2 crores, 2.9 crores to 3 crores. BMI associated hyperglycemia, 1.4 crores. BMI associated high triglyceride, 4.4 crores. Look at the number of children BMI attributed metabolic syndrome is 8.4 crores. Just imagine you're giving the other atlas has given the number, it will increase to 2040. Not far away, 14 years will go like this. You see the number that we have, 14 years. That's, I told LSM that I should give this course and this talk, and they agree. And I'm showing is what is happening. Now, this Indian data, now the prenatal people who are obese are 13.4%. Prenatal summary exposure to tobacco is very less, very, very thankful, 0.6%. The infancy summary exposure to suboptimal breastfeeding, still one-third of the mothers, either they don't get enough milk or they substandard breast milk feeding. School-age children into primary school receiving school meals is 36%, and school-age adolescents, 74%. That is one of the achievement by Government of India. We have a Abhijan called Poshan Abhijan, Nutrition Abhijan. It's an Abhijan, it's an expedition. So we have made the school children should get eggs, irrespective of states and politics. We have made it sure that 74% of adolescents get some food. Now, policy actions, implementation of the International Code of Marketing of Breast Milk Substitutes, 78 out of 100 marks we have got. Now, national guidelines of physical activity for children and under 5 years. Yes, we have. We have the guideline. Sorry, we do not have the guideline. I'm extremely, we do not have any guideline. We are going to prepare it. Policies to promote physical activity in the child care setting, we have a guideline. School food provision, nutrition goals, yes, we have. Now, we have not yet addressed the obesity goals. We don't not yet address the school education program centered around obesity, which is mandatory. So this atlas has given a bird's view of where we stand today. It's a mixed bag. It's a mixed bag. No, I will not go into detail because no, I will save time for some discussion. So I will not detail that. Obesity environment is because of surrounding promoting weight gain, easy access to junk food, fast food kills fast. Fast food kills fast. That is one of the Government of India slogans. I will not detail that. This is important. Biological factors. Genetics, family history cannot choose our parents, but we cannot give to children junk food and sugary beverages, overeating, unhealthy snacking, physical inactivity not to be tolerated, excess screen time not to be tolerated, poor sleep, and emotional eating. No, it is said biology loads the gun, but environment triggers it. Social drivers, family income. Where the family income is low, food is bad. They take more fast food. Parental education, occupation, housing and neighborhood. Who will walk on the roads? You will be killed by the accident. We need housing, neighborhood, school environment, cultural norms, limited healthy food access, and unsafe spaces that we have to address. This is one important thing. The life course perspective. Obesity risk begins early in the life. So infant starts from prenatal period, childhood, maternal obesity and GDM gives rise to obesity in the child, and that is transferred as a transgenerational transmission as type 2 diabetes and obese type 2 diabetes. What is the downstream effect? I have told you all this: pre-diabetes, type 2 diabetes, dyslipidemia, hypertension, metabolic syndrome, and NFL. We call it CK, Mayur is here, Mayur said, we call it CKLM. L we add, H we add for the hepatic muscle, and that is very important, we can present it. Now, there are complication and comorbidities, vascular complications in the adolescent type 2 diabetes. Now, the search and today's study and our YDR has been harmonized, paper has been published, saying that we almost have similar or little more complications. These children have cardiovascular vulnerability, see the lipids in the arteries, they have psychosocial outcomes, they have great economic burden. Now, the spectrum prevention, we always advise primary prevention, prevent obesity before it starts, healthy diet, physical activity, reduce screen time, school and policy measures. Secondary prevention, BMI screening, identify high-risk adolescents, counsel lifestyle modification. Tertiary prevention, treat the comorbidities, multidisciplinary care, and prevent long-term disability. So it is said, the earlier the intervention begins, greater is the life. Sir, I'll just summarize Malaya's talk. Very important that in the Chicago School of Medicine, they said that first year control matters. That's what Malaya said in this talk. If you control diabetes, hypertension, lipids, everything in the first year of diabetes, diagnosis, the life is, they call it a trajectory, the entire trajectory changes. So we are now emphasizing that early onset. School level strategies, there are many. I have got a book on this, I'll hand it over to you. Healthy canteen. How many of us have healthy canteen in the schools? Restriction on junk food, bar the junk food, like we are barring the drugs and the cigars, bar the junk food, sugary drinks, absolutely harmful. Regular physical education, sports. The day should begin with sports and nutrition, health education, growth monitoring. Food system, nutrition policy. These are, we are now taxing the sugar. We have taxed the tobacco many times. You will be surprised what the tax level being thought of for the next budget, and the sugar to be taxed, and on all healthy food will be taxed routinely. Now we need urban planning, we need parks, we need roads to walk, we need gardens to walk, and we have to useful tools include that we have to monitor and keep the adherence. Therefore, early life intervention is important. So we have to integrate the policy of the health, nutrition, food, urban planning, community program. And we know how to assess obesity, I'll details of that, but the slogan is assess, identify adolescents which are obese, and screen them for comorbidities like diabetes, hypertension, etc., and give the appropriate treatment. Dear friends, pharmacological intervention I will not touch upon because that is not a Government of India. We have banned promotion of the anti-obesity drugs in the public. Directly to the patient, they can no more promote. It is banned, they cannot promote it. Now, I will not intervention, but to suffice to mention that there are evidences today that both metabolic surgery, the drugs that we use for the adults are also useful in children. we have written a book called the AI and Digital Health in Adolescent Obesity. I'll pass it on to you. It is about the data-driven care and making it accessible by the AI and mobile health. Very much important. So better engagement, continuous monitoring, scalable intervention, improved access, must address the privacy, must be addressed. The precision medicine is there. We do not say one size fits all. Therefore, we have developed Kishore clinics, adolescent clinics. We have a Kishore reproductive clinic also. Now, India, there are many innovations. The last 3 slides. India faces a rising challenge with adolescent obesity affecting millions linked to poor diet, inactivity, and urban lifestyle. Government strategies emphasize multi-sectoral programs and key government strategies, Rashtriya Kishore Swasthya Karyakram. This is only focused on adolescents, called RKSK. It targets only 10 to 19 years, very successful program. It gives nutrition counseling, obesity reduction, and adolescent organization. Poshan Abhijan, I told you, we call it Eat Right in the house, Eat Right India, Eat Right School, and we have Fit India movement. Dear friend, we have got school-based intervention to innovate public health approaches. One is Chetana, other is Mark, and we'll discuss about it. That is centered around nutrition education and reducing junk food. Policy proposals include surgery drink and the NP for national program for NCD, we do that. So impact statement is the adolescent obesity is not a local problem, it's a worldwide problem. And it doesn't go away with prescription, it goes away with the policy. That policy, what I'm talking about today, is not about the choices, it's about the system that shape those choices for the adolescent to take it. So therefore, when adolescent lives strongly shapes, if you have an obesogenic environment, the child will become obese. State variation is driven by the differences in urbanization, lifestyle pattern. Behavioral habits are very important, and adolescent obesity can be controlled. It's not excess fat, is the starting point of early metabolic disease. Therefore, digital tools can turn the skin time, and we can have a very healthy population. Thank you very much for patient hearing.
Thank you, sir. Thank you so much. I know it's a very short time for you to talk so much about all this. It was really nice to listen to you. Just like how AK-47 fires, you were really firing. It was really good actually to listen a lot of things. Yes, the school health is one thing which you have to really think. You really nailed it.
We have made from class 7th to class 9th 2 chapters on the healthy eating and on the NCD prevention. 2 chapters everybody has to. It is not like writing about the judges and get the book has to be booked. We have written it in the books by the experts, so it is every NCRT book, class 7th, 8th, 9th, has chapters on the NCD and how to prevent it, how to prevent obesity, what to take. Dear friends, you think PSM is a gone case. If you want me to take a subject today, I will not take diabetes endocrine. I'll take PSM. Because we have understood we are treating only one. By the preventive measures, we can treat millions.
So in the interest of time, I'm just trying to thank Dr. A.K. Das for his excellent talk. Thank you. Over to the organizers.
Thank you so much, doctors.